our next speaker is Professor Yusuf Abu... oh, sorry, he hasn't appeared. Is it Andrea? Sorry about this. So our next speaker is Professor Andrea Genazzani, who's going to talk to us about the central effects of progestins used for hormonal contraception. Professor Genazzani is from the Department of Obstetrics and Gynecology at the University of Pisa in Italy. So thank you very much.
Thank you. Ladies and gentlemen, thank you very much. And I'd like to express my gratitude to Professor Gamal Serur also for being here today. And I will talk to you about a chapter which seems of relevant importance now, which are the effects of progestin used for hormonal contraception. First of all, I would like to remind you that when we speak about intracerebral steroid level, we have to be aware that we have certainly that originating from peripheral endocrine glands over adrenal or placenta or the testis who can reach, but also we have the intracerebral metabolism and local synthesis. As you know, the brain is an organ who, as the adrenal, the gonads, and the placenta can have a very active steroidogenesis. Only it cannot produce mineral corticoids, it cannot produce glucocorticoids, and that steroidogenesis is not activated by a proteic hormone such as CTH or LH. That steroidogenesis is regulated only by the local production of the enzymes responsible of the steroid metabolism. Then is the local presence of these enzymes who transform cholesterol to pregnenolone, and then from that it moves to androgens or to progestin, and then later on to estrogens too. Then this is associated with, and it's also present in peripheral nervous system, and is a fundamental phenomenon of the biology of the brain. And I would like to remind you that we are all at the beginning of our embryonic life, we have all a female brain. But the female brain is transformed in a male brain by the rise of testosterone from the fetal testis, and which is also potentiated at the second, third month of extrauterine life by the short puberty who reactivate testosterone production. And this means that only by that one, we have a huge series of functional sex difference. We have different estrogen, progesterone, and androgen receptor expression in the brain areas. We have different receptor polymorphism, but mostly we have different neuronal subpopulation in the different brain areas. Then you understand the importance that one, because this brings that we have two different gender identity, we have two different sexual orientation, a cognitive dimorphism, a different response to hormone therapy, but mostly that we have a different prevalence of neurological and psychiatric disease. For example, the women, they suffer more of depression, and the men of schizophrenia. This was associated and done by that one. Then, moving on, the women also, they have a specific female brain vulnerability, which is depending from genetic factor or interpersonal factor, developmental and cultural factor and social factor, but also is strongly sensitive to the changes of steroid hormones that are ultradian secretion dependent, circadian secretion dependent, monthly secretion, and also seasonal secretion. And I would like to put your attention that on the mechanism by which sex steroids they can impact the central nervous system. I already mentioned the organizational, but they have a strong effect as activation for sex-specific hormone action. They modulate the neurotransmitter function and the receptor subtype crosstalk. They are able to induce specific receptor. They have either genomic as well membrane effects. They can control oxidative metabolism and apoptosis. They have specific neural and glial effects. They can activate the production of specific synaptosome. They can control inflammation, and they are also very sensitive for their neurovascular effect. And just to mention what are the neurotransmission and brain function. For example, the role of estrogen acting through estrogen receptor alpha and beta, they can activate through, for a brain cholinergic, memory and learning. In midbrain, they activate noradrenaline and they influence arousal. by basal forebrain, by dopamine attention. In midbrain, dopamine is fundamental for the rewarding and also for the addition, but also for the addition mechanism. And in midbrain, serotonin control, mood, integration, and affect. And I would like also to mention the effect of central opioids and the effect also of neurotrophins, who can control mood, pain threshold, and integrate the neuroendocrine function. Then by that way, you clearly understand how hormones are of major importance. But now I want to go to another chapter, which is not so frequently followed. Here are the progesterone and its metabolite effect. They can interact also for genomic action and the non-genomic. And they can influence the GABAergic agonistic system, then they can have potent anxiolytic effect. They can influence either monoamine oxidase as well catechol-orthomethyltransferase, acting on noradrenaline and dopamine turnover, and then controlling also by their effect on serotonin turnover mood disturbances. They can influence opioid activity and then have an importance in mood and pain threshold, and they have huge series of effects on neurotrophins who can activate who can control neuroendocrine function and different cognition. But I want to put your attention on a critical point. The capacity of the brain to produce allopregnanolone. Allopregnanolone is produced by the 5-alpha reductase, who bring to 5-alpha dihydroprogesterone and then 3-alpha-hydroxysteroid dehydrogenase. These enzymes are expressed either in neuron as well in oligodendrocyte and in astrocyte type 1 and type 2. And these are responsible for the production of allopregnanolone. Allopregnanolone don't bind progesterone receptor, but link directly GABA-A receptor. And by that way, the psychopharmacological mechanism effects of progesterone, they should be, according to the dose, either sedative or hypnotic, anxiolytic, anticonvulsivant, anesthetic, and also analgesic. Later on, I would like to put your attention on another chapter. And that chapter is that one. In the brain also, in all areas, you can see frontal cortex, the encephalon, hippocampus, the amygdala, and the various hypothalamus and so on, we have the capacity of DHEA to be transformed till testosterone, and from testosterone, either 5-alpha reductase produces dihydrotestosterone who bind to androgen receptor, but it can be further metabolized to alpha diol who go to GABA-A receptor, or can testosterone be aromatized to estradiol? Then the key factor, the key enzymes responsible in the site of the brain of the major hormonal factor are the brain aromatase and the brain 5-alpha reductase type 1 and type 2. And when we see what are the non-reproductive central nervous system function impacted by sex steroids, I would like to remind you how they are fundamental for human beings, because affective state, mood, sleep, libido, sexuality, social behavior, but also motor coordination, neuronal excitability, the pain threshold, the auditory threshold, the cognitive function, and a series of neuroprotective mechanisms. Then, these are the women. The women, they have, during their fertile life, all these beautiful changes of estradiol and progesterone, which are not only efficient by themselves, but the brain cyclicity, which included changes in behavior, in mood swing, depression, you can see in the slide, is strongly affected by a huge series of other factors who changes, such beta endorphin, serotonin, dopamine, noradrenaline, GABA, and so on. Then this is the woman. We, the men, we are more stabile, but the women that have this oscillation who have a huge effect on their personal life. Then we had the problem of oral contraceptive. Oral contraceptive, they can block the ovulation by the capacity of progestogens and also progesterone, but only at higher doses, to block the GnRH production and the LH peak. You know, mood changes are one of the controversial effects of oral contraceptive, and retrospective studies reported negative mood changes in 10 to 30% of users. And changes in mood, especially in depression, is one of the main reasons given to discontinuing OC. Then it affects the compliance. But I would like to put your attention on another study, which was presented exactly the day when I have presented the following slide that you will see later on, from Lidegard. He have shown that the administration he published that one in 2016, did either oral contraceptive, progestin-only contraceptive, the patch, the vaginal ring, the levonorgestrel only, according to the age of the subject, have a huge impact on depression. But this happened, you can see in the second chart, this happened mostly at the beginning of the treatment. This was something of huge importance. But I would like to show you that other slide of another study, which is the increase of suicidal behavior. The increases of suicidal behavior at the beginning of the treatment. You can see mostly at the beginning of the treatment, it disappears after 1 year of treatment, and mostly in the younger individual. Then this what indicate this one? This indicates that, you know, I have no time to go, but in the suicidal area where suicide is regulated in the brain is full of huge amount of progesterone receptor. Then progesterone can be active on that one. But what are the factors who can control this action is the capacity of progesterone to be transformed in allopregnanolone. Then, going on, I've got the time. Okay, this is another study showing that in some studies hormonal contraception can be reduced, cannot change and can improve the mood. But I would like to go on in your line. Then, is the emotional side effect of oral contraceptive pharmacologic or by a psychological mechanism? First of all, who are the vulnerable women? The vulnerable women, and the women who can develop this kind of sensibility and behavior, are those who had a previous depressive episode, anxiety, or premenstrual syndrome, women exposed to strong socioeconomic factors, women who have a huge difficult interpersonal relationship, and women where psychological expectation and indirect pharmacological factor they can act, and certain personality traits. But look on that one. Oral contraceptives have been associated in women with detachment and mistrust to an increase of depressive aspect. Then some aspect of the personality, which very rarely is explored by the gynecologist in our office, is associated with that one. And the question is the dose and type of estrogen molecule important? Is the progestin molecule used? And what are the factors? If you go to see the progestogen that we use for contraception, you can see that some of them, they are originating from mineralocorticoids as spironolactone. Others are originating from 19-norprogesterone, 17-hydroxyprogesterone, or 19-nortestosterone. The hydrogesterone is not used in contraception. It's coming from the exposure of progesterone to ultraviolet ray. Then the problem is, are all these the same? Or this one, they are different. When we go to see the data in the clinical data, you can see that, for example, monophasic pill with desogestrel provoke less negative mood changes in comparison to levogestrel, this one. And mostly, if you use chlormadinone acetate as a progestin, this strongly improve either in the pill starter as well in the pill switcher, strongly improve depression. The same is with drospirenone, which is a mineral corticoid originating progesterone. The same has been seen also in a series of studies. I don't want to go in details with dienogest. But until now, the progestogen used in contraception, they were only evaluated on the basis of their effect on estrogen-primed endometrium to control that one. None of them have shown if what they are the effect done on mood, on anxiety and depression. And this was one of the faults, because experimental studies in animals have shown that the oral contraceptive with levonorgestrel decreases brain content of allopregnanolone. This is an animal model, which is the rat, which is very similar. They are different, but it's very similar to human metabolism of steroid in the brain. then the reduction of allopregnanolone is something. And another very interesting study have shown that long-term administration of levonorgestrel decreases allopregnanolone levels and alter GABA-A receptor subunit expression. You know, to change the structure of the GABA-A receptor completely modify the response of the GABA-A receptor. Then we have seen another study have shown, have reconfirmed that we have a decreased allopregnanolone induced by hormonal contraceptive, which is associated with reduction in social behavior and sexual motivation. The reduction in social behavior is directly touching the quality of life of the individual. Then the question arises, this can happen also in humans, there is any responsibility? And then we went to this study, which was published 25 years ago by Thomas Rabe, a fantastic study showing what are doing the different progesterone in comparison to ethinyl estradiol in violet who have no effect, and in comparison to the major inhibitor of 5-alpha reductase activity, which is finasteride, not a steroid, all the other one, they give a reduction of 5-alpha reductase activity. And then we move to another point. Is that one standardized is always the same in individual? Not. Individual have, as for many aspects of our biological life, we have an individual signage and an individual vulnerability. Then we have made a series of studies in animal also, more or less 15 years ago, showing the effect on the different progestogen on the brain allopregnanolone content. As you know, the brain allopregnanolone content depends from the local production, And we have evaluated either the neocortex, which is responsible of higher brain function than the thought, the action, the hypothalamus, from homeostasis, stress response, autonomic nervous system, and so on. The hippocampus, which represents the archicortex, where we have the elaboration of memory and the cognitive function. And you can see here, these are the data in the different area and in adrenal cortex and in the serum of the animal exposed to micronized progesterone, then increasing the total amount of precursor of allopregnanolone. It associated with a beautiful increase of allopregnanolone everywhere. If you give if you give chlormadinone acetate, it don't have any effect, only in the hippocampus. If you give drospirenone, no effect at all. If you give nomegestrol acetate, only an increase and a slight reduction in adrenal cortex. But in contraception, all these are used together with an estrogen. Then, what first estrogen is doing? Estrogen increased everywhere, but not in the adrenal cortex, the allopregnanolone production, because they activate 5-alpha reductase activity. And if you give micronized progesterone to this, this is further enhanced. If you give drospirenone, no changes. If you give nomegestrol acetate, we have an increase in hippocampus, hypothalamus, anterior pituitary, and a minor effect in adrenal cortex. And if you give chlormadinone acetate, also you have an increase. Then, going back to the clinical data that they have observed, that this kind of steroids, they are associated with a protection against depressive mood, and also given in pill switchers for depression or as a first progestogen, they are associated with an improvement. This is demonstrated by the fact that in biology, really these steroids, they don't have this effect. And I would like also to show you another data. Our lab was working on endogenous opioids for many, many years. And as you know, in premenstrual cycle, in premenstrual dysphoric disorder, and in pain, I make you my compliments for the gabapentin data that you have just shown. You can see here that PMDD subjects have lower pain threshold tolerance and lower beta-endorphin level. You can see lower beta-endorphin level and lower tolerance. If you administer to them, you know, this is what the control, luteal phase and tolerance. And if you administer to them beta-endorphin, what can happen? Chlormadinone acetate increases beta-endorphin in anterior pituitary and neurointermediate lobe. Medroxyprogesterone have minimal effect. Drospirenone increases everywhere. And no mesosterol acetate also increases at the hippocampus hypothalamic level. Then all of these steroids, they have to be evaluated also for this function, and not only for the effect on progesterone, on endometrial exposure to estradiol. Then the critical issues are the brain content. Then changes in plasma level do not necessarily reflect the tissue level. Then we cannot evaluate the brain content in humans, but we can extrapolate by studying their action. And the conclusion, I am in time, is that one, brain development and senescence are regulated by allopregnanolone. Reproductive behavior changes are affected by allopregnanolone. Endogenous sex steroids modulate synthesis, metabolism, and action of allopregnanolone. Physiological modification of endogenous steroids modify behavioral changes associated to allopregnanolone level, and exogenous steroids differentially modify synthesis, metabolism, and action of allopregnanolone. Then direct or indirect hormone manipulation may be a strategy to preserve allopregnanolone effects during the reproductive senescence. Then, by that way, I think that all contraceptive use, for the risks that Hildegard have shown us and that have been published by others, they have also been evaluated by the capacity and possibility that they can positively interact with the production of substances who regulate mood and behavior in humans. I thank you very much for your